Our first speaker really this morning is Dr. Stephen Pantilat. Stephen Pantilat is the Cates, Bernard, and Hellman Distinguished Professor in Palliative Care and the inaugural Chief of the Division of Palliative Medicine at UCSF. Dr. Pantilat is an internationally recognized expert in palliative care. Dr. Pantilat has published over 140 peer-reviewed scientific papers, authored more than 24 book chapters, and co-edited with colleagues at UCSF 2 textbooks on palliative care titled Care at the Close of Life and Hospital-Based Palliative Medicine. Dr. Pantilat is the immediate past president of the Board of Directors for the Palliative Care Quality Collaborative, the nation's leading organization dedicated to improving the quality of care for seriously ill people and their families. He is the author of Life After the Diagnosis, Expert Advice on Living Well with Serious Illness for Patients and Their Caregivers, published by DeCapo Lifelong Books in 2017. Dr. Pantilat and the palliative care team at UCSF are featured in the Academy Award-nominated Netflix documentary, Endgame, and in 2018, he gave a TED-Med talk. Please join me in giving a very warm welcome to Dr. Stephen Pantilat to kick off our first session of the day, Contemporary Clinical Challenges in HD. Thank you.
Thank you so much. Thank you. So what is palliative care? Simply put, palliative care is medical care focused on improving the quality of life for people with serious illness. I don't need to tell the people in this room that Huntington's disease is a serious illness. It is an illness that impacts every aspect of someone's life, including their family. It has important implications for people's quality of life. It impacts physical symptoms, emotional, psychological, spiritual, caregiving, family. So it has myriad impacts as a serious illness. And the goal of palliative care is to improve the quality of life for people with serious illness. And in our field, certainly it extends to neurologic disease like Huntington's disease, like ALS, like Parkinson's disease, and to many other illnesses. We'll focus today, though, on how we can think about palliative care improving the quality of life for patients and their families for people living with Huntington's disease. One challenge that we have is that often in healthcare, we think about this idea, we worry that you have to choose between quantity and quality of life. And the way that sounds often is, if you want quality of life, then you really just have to focus on that. Just focus on your symptoms and don't think about any treatments that might extend your life, that it's really about quality of life. And you're going to exchange some quantity in order to get that quality. But if you want quantity of life, if you want to live long, then what you really should do is just accept all the potential treatments that are available, including being in the hospital, including being in the ICU near the end of life. And the fact is that you can live well and long with palliative care. And I'm going to share with you some data from randomized trials that have been done in many different illnesses, including in Parkinson's disease, which I think is probably the closest to what could be applied directly to Huntington's disease. And the take-home message that I want to leave you with is that palliative care helps people live well and it helps people live long. And that it can have profound impact on the quality of life of people with Huntington's disease. So let me just share with you some of the benefits of palliative care. These are benefits that come from randomized controlled trials. I think the best known one is in cancer. It was a trial of 151 people with metastatic lung cancer, which I realize is a very different disease, both when this study was done, it was published in 2010 in the New England Journal of Medicine. And lung cancer is a very different disease today, and it's a very different disease from Huntington's disease. And yet I think there's a lot that we can learn from this important study. And I always say if there's one study you're going to know, this is probably the one you want to know, although I think for this group, if there's one study you want to read, I would read the study by Benzie Kluger and colleagues published in JAMA Neurology. It was a randomized trial of palliative care for people with Parkinson's disease. But the study I want to tell you about was done at Massachusetts General Hospital, at Harvard. It was 151 people with a new diagnosis of metastatic lung cancer, which is a serious illness. All the patients received standard of care cancer care at Harvard, which is apparently very good. I like to say it's not UCSF, but apparently the care at Harvard is good. Half the patients were randomly assigned to receive palliative care in addition to standard oncologic care. So what did they find? Basically, they found everything good that we want to have happen for people happened to the people who received palliative care, which is to say they reported a better quality of life. They had improved symptoms, less shortness of breath and less pain. They had less depression. Interestingly, it was not because the palliative care team prescribed more antidepressants. That was not the reason. There was something about the relationship, about how they were cared for, that actually eased their depression separate from receiving antidepressants. They were less likely to get invasive care at the end of life. So they were less likely to end up in the intensive care unit on a ventilator or to be coded at the end of life. There were better outcomes for loved ones, not in this study, but other studies, including studies of hospice, that shows that if a patient spends 7 days or more in hospice, their spouse is less likely to die in the 18 months after the patient dies. So think about that for a moment. An intervention focused on the patient to improve their quality of life and their care not only improves care for the patient, but improves care and reduces mortality in their loved one. There are not many interventions in healthcare that are able to do that. In fact, the only one I can think of is smoking cessation. Right? If you can get someone to quit smoking, their family is no longer exposed to the secondhand smoke and their health gets better. So that's it. So more than 7 days in hospice has a profound impact. Higher satisfaction with care, lower healthcare utilization. People were in the hospital less, spent fewer days in the hospital, which is what most people want, particularly when they're very sick. They don't want to be in the hospital by and large. Some people do, but most people don't. An equal or longer lifespan. In this study, the people with lung cancer who received palliative care lived longer by 3 months. They lived a year compared to 9 months, which is profound. Now, not all studies of palliative care show that people live longer, but there's never been a study that shows that people live less long. And that's true in the study of people with Parkinson's disease. So you can live as long and live better. But only specialty palliative care has been shown to provide these benefits, to achieve these outcomes. So working with a specialty palliative care team, which is really going to be my message today, is for us to partner together to take care of people with Huntington's disease, will likely provide many of these outcomes for patients living with this serious illness. I like to say if it were a drug, everyone would get it. If there was a drug that achieved these outcomes for cancer or for Parkinson's disease, you know that you would give it to everybody, because these are really profound outcomes with no side effects. That's the other thing, is that palliative care does not have side effects, does not have bad side effects. So what does this look like, and how do we talk about it, and what are the components of palliative care? So let me tell you what I tell my patients when I see them in my clinic or in the hospital. I say, we do 3 things in palliative care. We're not the experts in your illness. I'm not a Huntington's disease expert. I'm not a Parkinson's disease expert. I've learned a lot, but I'm not an expert. You have doctors and nurses and social workers who help you with that illness. Our job is in 3 areas. 1, symptom management. So we help with symptoms, pain, shortness of breath. In a study of 101 people with Huntington's disease in hospice, a third had pain, severe pain. Another third had anxiety, shortness of breath. So symptoms are common, And being able to manage those symptoms expertly can really improve someone's quality of life. The other bucket of care that we do is communication and decision-making, helping people decide about treatments, about the kind of treatments they want going forward, where they want their care to be. This is something that we focus on very intentionally in palliative care, working with patients and their families to really help them understand who's going to make decisions for you, what kind of decisions are most important, what's most important about your quality of life, and we'll talk more about how to do this. And then finally, we provide psychosocial and spiritual support, recognizing that serious illness is not just a physical experience, a medical experience, but it is one that impacts your entire life, all the aspects of your life. We work with an interprofessional team, like I know many of you do. We have nurse, social worker, chaplain, physician, pharmacist, psychologist on the palliative care team. Because if you really want to address the issues that matter to people, you need to have team members who have this area of expertise. And because of the spiritual issues that are invoked in serious illness and at the end of life, it's really important that we have chaplains, for example, on our team. What I tell patients in clinic, well, I always ask my patients in clinic or in the hospital, what have they heard of palliative care? And the good news is that over the 25 years I've been doing this, more and more people have at least heard about it. Some people have actually Googled it. Some people actually know what it is, but not everybody does. So I always ask them. So I had a woman in my clinic. She was 80 years old. She had Parkinson's disease. I said, well, tell me, what do you understand about palliative care? And she said, oh, you're the team that takes people from sick to dead. I sort of thought about that for a moment. I thought, well, that is not untrue, actually. But I said, well, how about this? We're going to provide an extra layer of support for you, and we're going to help you live as well as possible for as long as possible. And she said, oh, I like that better. I said, good. That's good, because I do too. So that's one of the things we talk about is an extra layer of support. Like you have your team. You have your Huntington team. You have your primary care doctor. You may have other doctors as well. We're an extra layer of support. And who doesn't need that when faced with serious illness? So what could this look like? I want to show you a diagram. This is my version of what is a very common diagram in palliative care. If you've heard a palliative care talk, you might have seen a diagram like this, but I just want to go through it with you. What this shows is that even on the day of diagnosis, when most of the focus may be on disease-directed treatment, there's still a role for palliative care, because even at the moment of diagnosis, people have questions about, what does this mean for me? How long will I live? Am I going to die? Right? You can imagine that. You've been there when patients get a diagnosis. All these ideas are running through their head. It's not to say that only palliative care teams know how to talk about these things, but we do have an expertise in how to address these issues that patients raise. The focus appropriately early in disease is on disease-directed treatment. And how do we manage the symptoms and all the issues that go on in the management of Huntington disease? What about clinical trials and helping patients have access to the best care for their illness? And yet there's clearly a role for palliative care as well. In fact, when in a qualitative study of people with Huntington disease and their families, what they said was they actually wanted all those components of palliative care. So they wanted a focus on symptom management. They wanted to be able to communicate about their illness and about the future. And they wanted help with psychological, emotional, spiritual, and practical issues. So they wanted all those components of palliative care. And they wanted it from the moment of their first symptoms. That's when they wanted impact. And I think that may be a very good place to think about a referral to a palliative care team. But what you can see in this diagram is that over time, palliative care may play a larger role in the care of a patient because either disease-directed treatment is no longer available or because the patient doesn't want it anymore. And we see that a lot from our patients, where they say, you know what, I'm tired. I don't want to come back to the hospital anymore. I'm tired of these treatments. I really want to be able to stay home. I want to be able to just focus on being more comfortable, having fewer interventions, fewer doctor visits. And so the diagram shows, however, that even near the end of life, there's still a role for disease-directed treatment, and most of our patients are still engaged with their specialty teams up to the end of life. You see that there's a line for hospice. That's a service in the last 6 months. I'm going to talk about hospice in just a moment. The green bar just reminds us that we play a role in healthcare in bereavement with the families of the patients who have died. You see that the intensity of grief does reduce over time. It does. In fact, grief that is profound more than 6 months after the death of a loved one can be considered complicated grief and needs treatment. Complicated grief is a very big risk factor for suicide, for example. But by 6 months or a year, grief, the acute pain of grief has often eased. But you see that there's a tail that goes off the slide just to remind us that it never goes away. You know, people say, oh, you'll get over it. But nobody gets over the death of a loved one. Sure, it's less painful, it's less acutely painful. And to think about, how do we reach out to the family members of the people we've cared for? Do we send, on our inpatient palliative care team and an outpatient, we routinely send them cards to the family. One of our team members calls the family members just to check in, to let them know that we also acknowledge what happened. In palliative care, every 2 weeks we have our team meeting, and we always review deaths. In palliative care, there's a lot of that, but it's a way to acknowledge what's happened. As I said, I tell my patients, my goal is to help you live as well as possible for as long as possible. And that is my goal. Patients want to enter clinical trials, we support them. If they want a liver transplant, we do everything we can to make sure they get it. Because there's a lot that we can do in healthcare to help people live better and live longer. So I want to take a moment just to talk about hospice and palliative care, because there's often confusion even in healthcare. And so I just want to take a moment to kind of go through the similarities and differences. And if I had kind of a conceptual framework for you, it would be that palliative care is the universe of care that is focused on improving quality of life for people with serious illness. And there are many ways to deliver it. We have inpatient teams, we have outpatient teams, we have home palliative care, we can have palliative care in skilled nursing facilities, we do a lot of telehealth palliative care. Hospice is one way to deliver palliative care. In the United States, it's a very specific type of service with rules around it because of the way Medicare first established hospice care in 1982 and the rules around payment for hospice. Hospice is focused on serious life-threatening illness, and so is palliative care. It includes an interprofessional team, and so does palliative care, as I told you. Hospice requires a 6-month prognosis and is really focused on end-of-life care. In fact, the median length of stay in hospice in the United States is 18 days. 18 days. 35% of people who receive hospice care receive it for 7 days or less. Remember, I told you that the benefits of palliative care for the spouse accrue in a stay of 7 days or more. So many people are being referred in the very last days of life, where they don't really benefit as much as they might. And what we typically hear from patients, from family members actually, is, I wish I had enrolled in hospice sooner. So something good for us to be thinking about. Whereas for palliative care has no prognosis. Someone with Huntington's disease could be referred at their first symptoms and follow with a palliative care team for years and perhaps decades. You have to forego disease-directed treatment and hospitalization when you're in hospice. That is not an issue in palliative care, where you can get concurrent disease-directed treatment, including hospitalization. Hospice is by and large provided at home. There are some inpatient hospice services. We have one, but by and large, hospice is a home-based service where palliative care can be provided anywhere there's a patient. So in hospital, clinic, telehealth, home, skilled nursing. Fewer than 5% of people with Huntington's disease use hospice. So for an illness that is as severe as Huntington disease, that's a really low percentage. It is still true in the United States that most people who receive hospice have a diagnosis of cancer, but that is changing over time. Nationally, 45% of people, of Americans who die, make use of hospice. When I first started in this work 25 years ago, that number was 15%. It is now up to 45%. I think a lot of opportunity here. So the worry is that somehow we have to choose between quantity and quality of life. But what I want to tell you is that we can do both for our patients, and we can focus on both. And I think in partnership, we'll be able to help people with Huntington disease and their families live as long as possible and as well as possible. I think the next worry is that talking about what's really going on will destroy hope, and that we have to stay sort of optimistic and hopeful. And to do that, we really don't want to focus on all the bad things that are going on and all the bad things that may be coming up. And what I want to really emphasize is that talking about hope encourages it. That if we can talk with our patients about what's important to them, what they hope for in the future, can actually encourage hope. And that's something that we can help our patients with. We don't create the hope, but we can really encourage it. And the way I think about it is by asking what I call golden questions. Golden because they are so valuable in what they reveal to us about what's important to our patients. And the first one is, when you think about the future, what do you hope for? And that we think that patients are focused on cure, and they are, and they should be. And we should hope for that for our patients. But they hope for a lot of other things as well. And there's a lot that we can help them with by asking them what it is they hope for. So a few years ago, I was taking care of a woman in the hospital, Mary. She was 72 years old. She had interstitial lung disease. She was admitted to the hospital with pneumonia. She was in the ICU on high-flow oxygen. She was very, very sick. It was clear that Mary was not going to recover from this. Her ILD was too advanced, and interstitial lung disease is a chronic scarring of the lungs for which there was no cure back then. There are now treatments to modify the disease, and people are living better and longer because of those treatments. It is still a really bad disease to have. So one morning on rounds, when we went in to see her, I asked Mary, I said, Mary, when you think about the future, what do you hope for? She said, oh, I want to see my daughter get married. I said, okay, well, that's really important. Well, tell us about that. She said, well, she's getting married in 10 months in the Napa Valley. And I immediately thought, I don't see it. I don't think Mary's going to be alive in 10 months. In fact, I'm sure that she won't. And she's never going to leave our ICU. So that's not going to happen. And so we talked about that. I said, Mary, this is really important, but I worry that you may not make it to that. And her daughter said, well, that's really important to me too. I'm going to get married right here in the ICU. And sure enough, 3 days later, Mary's daughter came to the ICU in this beautiful white wedding gown. Her fiancé was in a tuxedo. They put a corsage on Mary's hospital gown. Our chaplain, our palliative care chaplain, officiated at the wedding. There was family, friends, nurses, respiratory therapists, doctors, not a dry eye in the ICU. It was a beautiful wedding. It was not the Napa Valley, but it was a beautiful wedding. And Mary got to experience the thing that was most important to her, the thing she hoped for the most, because one, we had the courage to ask what she hoped for. And two, when she told us what she hoped for, we had the courage to say, if that's important, we need to do that now. Because, it's so easy in that situation to say, oh, you know what? I hope so too. And what does Mary think? She thinks she's going to make it, when I think the exact opposite. And I would submit to you that that's not hope, that is false hope. And that ultimately false hope is no hope, because it's not based in reality. We can't be in the false hope business. We have to be in the real hope business to help our patients have a chance to achieve the things that really are most important to them. And you might think to yourself, look, Mary, and I know many of patients with Huntington disease, you might say, what's the harm in a little bit of false hope? I mean, really, things are pretty dismal. Well, what's clear for Mary is that false hope would have had her miss her daughter's wedding. And there are many things that are important to our patients that they will miss if they don't know what the future holds. And by asking about what matters most to them, we can help them achieve it. We can't help them achieve all of the things they hope for, but we can help them achieve many of them. And to recognize that there are many hopes that coexist. Hopes about the legacy they want to leave, about friends they want to visit, things they want to say to people, things that they want to do. And to be able to tell people, hey, now is the time to do that. The flip side of that is to ask, when you think about what lies ahead, what worries you the most? People have a lot of worries about the future, about how they will be, how their family will be, what will happen to them, their prognosis. And if we don't talk about it, ask about it, and talk about it explicitly, then people start to guess, particularly about prognosis. And often they get it wrong. They're just looking for clues, but often they get it wrong. I don't know, how many people have seen the movie Ikiru by Kurosawa? Anyone seen the movie Ikiru? Okay, so I'm going to just briefly describe for you one scene in the movie. So Ikiru is about a middle-aged Japanese civil servant in post-war Japan. And we see him at work, and he's very diligently working, and his life is really kind of drab. And he develops this epigastric abdominal pain, and he decides he needs to go to the doctor. And he's at the doctor's office, and he's clearly very nervous, very anxious. This other patient sits next to him, and he says, hey, this is easy. When you go in to see the doctor, you ask the doctor what you should eat. If the doctor tells you what to eat, you're going to be fine. If the doctor says you can eat whatever you want, that means you're going to die. So sure enough, this poor guy goes in to talk to the doctor. And he's sitting there, and at the very end he says, so doctor, tell me, what should I eat? And the doctor says, you can eat whatever you want. And the patient assumes that he's going to die. By the way, this is not the movie. I didn't just ruin the movie for you. And he's right. Turns out he's right. And if you watch the movie, you'll see that there's an X-ray behind the doctor's head, and it's a barium swallow, and there's an apple core lesion in the stomach, and the man has gastric cancer. He assumes he's going to die. Turns out he's right. But so often our patients are not right, or they're not right in the right way, or they're wrong in the wrong way, and they don't know about what their prognosis is. They don't know what the future holds. They don't know what's possible. And being able to talk to our patients about that can really help them. And what we know from studies is that people with Huntington disease want to talk about these things. They want to talk about the future. They want to talk about their advanced care plan, who's going to make decisions for them and what kinds of decisions. And we know that when people have these discussions, it does not make them sad or anxious or worried, which is true in many different illnesses when this has been studied. And that people really appreciate these conversations. You can have these conversations with patients, and I really encourage you to. And I want to just emphasize again that it is something that we in palliative care really focus on a lot, think a lot about, and have an expertise in. And so I encourage you to think about that as another opportunity to engage with palliative care teams to see how we can partner together to take care of our patients. So the last worry that I want to talk about is this worry that we need to help people have a good death. And I think in our field, we've kind of perpetuated this a little bit in palliative care, that we're going to help you have a good death. But, one of my colleagues said, there is, the only good death is someone else's. And I think that's right. And, it's interesting, if you think about in our society, there is a lot of talk about what a good death looks like, and what do you imagine a good death being like, and so on. And I think to the extent that talking about a good death gets us thinking about our own mortality, and that idea gets us thinking about how we want to live our lives today because life is limited, I think that's a good thing. because life is limited, and how you spend your time and who you spend it with and what you do, that matters. And it matters in part because life is limited, or at least the idea that life is limited puts an urgency on today. So that's really important. But when I talk with my patients with serious illness, they are not focused on a good death. They are focused on a good life. And I would submit that our goal is to help people live a good life. And how are we going to do that in the face of serious illness, which is such a challenge? There are lots of ways that we can do this to help our patients live a good life in the face of serious illness. I think the other challenge is that we don't really make death good. Like even in palliative care, we're not making death good. We're trying to just make it less bad. And we're certainly trying to not make it worse than it would have been had we not been involved. I think, unfortunately, often the care that we're offering is making things worse rather than better. And the question is, how can we make care better for people, particularly at the end of life? And the truth is that often the end of life is not very good. And death is filled with sadness and grief and loss. And I just don't see that we do anything to make it seem good. Even at the end of a very prolonged and difficult illness, what you see is the sadness. So I took care of a woman, Betty. Betty was 102 years old when I met her. She was living in her own home, a beautiful row house in San Francisco. She was a retired high school biology teacher. 2 weeks before I met her, she had bought a new car, a Prius, and she was really proud. It was like a hybrid, and she was going to be like ecologically, in tune. A car that she was driving at 102 years old. So she was having lunch with her family, and she collapsed at the dining room table. They called paramedics. They brought her to the hospital. She got intubated. They did a CT scan, and she had a massive intracerebral hemorrhage, so a huge stroke that was not going to be survivable. That's when I got called. I went to see her in the neuro ICU. Her family was there. They were very sad. We talked. I said, wow, I'm so sorry that this happened. They said, thank you. I said, what? Did she tell you about the kind of care she wanted? Oh, yeah. She was super clear. She lived a very good and long life, and she did not want to live like this. And can we just, stop these machines and let her die peacefully? And I said, absolutely. And as I was in that room, I realized that there was so much sadness and grief. And I thought, this is about as good as it gets. You live to 102 on your own. You're still driving. You're still eating. You're totally clear in the brain. And then you die in an instant. I mean, this is it. So many of my patients tell me this is what I want. In fact, what they tell me is, I want to die in my sleep. I get that. In very old age, just die in my sleep, which I think that seems great. I don't think it's great for the person who wakes up in the bed next to you, because I think that's weird. It happens. It absolutely happens. In fact, with our patients with ALS, I often tell them or their spouse that this can happen because it can. People hypoventilate in the middle of the night. They die in their sleep, in fact. It's kind of creepy, even though it does happen. So it's something we do warn people about. But I thought, okay, this is the best it gets. This is it. And look at how much sadness there is. They thought she was going to be 105 or 110. They loved having her around. She was great. Now, I will say that when a 102-year-old person dies, there's not a tragedy around it. People don't go, oh, cut down in her prime. No, she lived a good, long life. I mean, there's a lot to celebrate here, but a lot of sadness as well. And that's very different than people who die much younger, in their 20s, their 40s, even their 60s. There's a lot of tragedy. We want to focus on helping our patients live well. And how can we work together to make that happen? I'm going to show you a picture now of my grandmother, my Safta. And I'm going to read something that she said from my book. But this is a picture of my Safta. She was 93 years old. That's my grandmother. That's in my aunt's house. And I'm just going to read an excerpt from my book that about her. Just take less than a minute. So my Safta used to sign birthday cards with the wish that you should live to 120. Moses lived 120 years. And a traditional birthday wish is that you should have a long life like Moses, the greatest teacher and leader of the Jewish people. But as she got older, my grandmother changed it just a bit. In Hebrew, she switched just one letter, and the change in meaning was profound. Rather than writing, live to 120, she wrote, live to 100 like 20. Live long and live well. My Safta understood that a good life is even more important than a long life. She lived that saying. She declined chemotherapy when she was diagnosed with lung cancer at age 93. Not all of us and not all of our patients will live that long, but we can all live the essence of that saying by living well and thinking about what it means for us to live well in the face of serious illness. So to wrap up, and when we think about palliative care for people with Huntington disease, remember, palliative care improves care for people with serious illness in all the ways that matter. It helps people with their symptoms. It helps them with their decision-making. It helps them think and plan for the future. It helps them psychologically, emotionally, and spiritually. And I know that you practice in interprofessional teams as well in caring for people with Huntington disease. You really have to provide the best care. I think there's incredible opportunity for us to partner. We've been partnering very closely with our colleagues in ALS and in dementia care, and in Parkinson's disease and in movement disorder. I think there's a great opportunity here to really expand our collaboration in Huntington disease. People with Huntington disease should receive specialty palliative care. I think the onset of symptoms is a good time to connect with a palliative care team for the first time. That's not to say they're going to see the palliative care team every month or every 3 months or maybe every 6 months, maybe once a year, but to really be connected and establish that relationship alongside the good care that you're providing. Huntington disease teams should partner with palliative care teams to provide the best care possible to our patients. Talking about what's really going on with kindness and compassion encourages hope. I think these are difficult topics, and thinking about the future and thinking about mortality, not in the abstract, but in the very real, can be very difficult. And so we want to talk about these issues, and we want to bring kindness and compassion when we do. So when you think about the future, what do you hope for? The goal of palliative care is a good life, to live as well as we can, hopefully to make the end of life easier, but really to focus on having a good life. That's my book that I would really encourage you to recommend to your patients and their families, and to think about whether, I think there are good lessons in there for all of us as healthcare providers. And I'm going to end, I'm going to give you a quiz. I don't know if they told you that, but I'm giving you a quiz. But I'm giving you the easiest quiz you've ever taken for 2 reasons. 1, you don't actually have to write anything down. And 2, I'm not going to grade you. So this is an easy quiz. The quiz makes the point about caring. I think ultimately what we want to demonstrate for our patients and for their families is that we care about them in the way that we talk with them, in the way that we attend to the things that are bothering them, in the ways that we try to reduce their suffering and to support them through a serious illness. The words we use when we talk to them, the way we respond to them and communicate with them, demonstrates that we care. I think particularly in illnesses where we're not able to cure the illness, this idea of caring for people is so important, and for them to feel cared for. And this quiz really makes that point. So again, you don't have to say anything, you don't have to write anything down, you just follow along. Okay, name the 5 wealthiest people in the world. Name the last 5 Heisman Trophy winners. Name 10 people who have won the Nobel or Pulitzer Prize. Name the last half dozen Academy Award winners for Best Actor and Actress. Name the last decade's worth of World Series winners. Okay, how'd you do? Terrible, right? Terrible. The point is that none of us remembers the headliners of yesterday, but think about it. These are no second-rate achievers. These people are the best in their fields, but the applause dies, awards tarnish, achievements are forgotten. Okay, so now I'm going to give you another quiz, and we'll see how you do on this one. List a few teachers who aided your journey through school. Name 3 friends who have helped you through difficult times. Name 5 people who have taught you something worthwhile. Think of a few people who have made you feel appreciated. Name half a dozen heroes whose stories have inspired you. Easier? Sure. The lesson. The people who make a difference in our lives are not the ones with the most credentials, the most money, or the most awards. They're the ones who care. Thank you very much. Thank you.
That was beautiful. Thank you so much, Dr. Pantilat, and thank you, Sherry, for bringing Dr. Pantilat to the meeting. Can we give him another round of applause? That was really just fantastic. Well done. Now, please welcome Dr. Burton Scott from Duke University to talk about his reflections on treating HD patients. Dr. Scott.
Well, good morning. Thanks to the coordinating committee and to Dr. Clausen for inviting me to speak to you. Inspired by Dr. Pantilat's talk, I would like to pay a brief tribute to Dr. Schulson, who was so eloquently tributed yesterday. But just in the spirit of goodness and kindness of him, I just wanted to remind folks of what Mary Edmondson had told us in the past. Most people, I bet most people in this room know Mary Edmondson, who's a wonderful HD psychiatrist who tells the story of when she was in a family with Huntington's disease, and she saw the ravages of the illness in her father. And that experience led her to, as a student, and I believe as a college student, she wanted to set up an educational event to help teach people about Huntington's disease, or at least gather folks with Huntington's disease and understand it better. And so she, again, as a college student, looked around for experts to help with this. And this was in the 1980s. She'd tell the story better than me because she lived it, but she told it to me. And she said that she asked Ira Schulson, this young, important young neurologist up in Rochester, to come down to this event that she was organizing. And he agreed most graciously, very kindly and graciously agreed to come down. And did a great job with this symposium that she organized. And also, at the time, Mary said she was struggling with whether, as an at-risk individual, she would pursue a medical school and a medical career. And she says that Ira at the time basically and told her, inspired her, or suggested that she pursue her goals kind of no matter what, whether she ended up getting the disease or not, but that she go forward with her dream and her goals. And she did, thanks to the generosity of Ira and kindness of Ira. And Mary became the psychiatrist that we know and love. But regarding my topic, so I was asked to come up with some reflections on Huntington's care in the last 20 or 30 years during the time that I've seen Huntington's patients. And I'm a neurologist at Duke University. I've been there since 1995. And in North Carolina, we see patients who come to clinic wearing various kinds of funny T-shirts. And this is an example of one of those where the shirt says, "Remember when I asked your opinion? Me neither." And this is an individual, a patient who's actually coming to clinic to ask me my opinion. But it also reminds me that everybody in this room has experience with Huntington's disease. You know, I've seen patients with Huntington's since 1996. Plenty of people in this room have seen patients longer than that, a lot longer. Or they're living with the illness, or they're taking care of somebody with the illness. So, you know, there's a wealth of experience here, but I'll talk a little bit about mine. So everybody's got their stories about the Huntington's patient, for example, who's a bricklayer whose first inkling of the illness is that whereas in the past he could think of a project he was going to do and imagine the number of bricks that he needed and just go out and get the bricks, but he lost that ability to do that. Or the kindergarten teacher who was having trouble coming up with curriculum tasks, and that was her first inkling of the problem. Or an underwriter who's starting to have trouble keeping up with numbers. Or a minister who's having trouble with his sermons. So some of these stories that I talk about do involve suicide, and so just be aware for folks that there is a national suicide network and phone line, the 988 Suicide Crisis Lifeline, which can be called or text. It's in English and Spanish. It's open 24 hours, and they have a website. But so one of our advocates, Ruth, told me, who has Huntington's in her family, that the first what really spurred her family to understand or to look into, stop ignoring the Huntingtons in their family, was this difficult event that was documented in this newspaper headline in 1983, when two sisters arrived at a motel. They didn't have a car. They didn't have luggage with them. They checked in using an assumed name and hung a "Do Not Disturb" sign on their door. They told the switchboard, which is how you talk to people in a motel back then before cell phones, that they didn't want any calls. And they bought a bunch of coffee. They made a few phone calls and didn't really come out of their room. And finally, after 4 days, the maid went in the room and found that these two sisters had overdosed and committed suicide. One of them was 51. She was a elementary school teacher for some 20 years, but for 5 years had not been able to teach and became more reclusive and depressed, and we had a psychiatric admission, but got herself out of that admission, signed herself out, but very depressed. And then her sister was 47 years old and was reading a lot about Huntington's disease because of her sister's difficulties, and then started to recognize symptoms in herself, and received the diagnosis a few months before these events. The illness was more hidden then, and the quotes in that newspaper article, an in-law said, "Well, what good is it to bring out the story? If you were in the same situation and knew all about the disease of Huntington's, you'd understand." And so the illness was hidden, more hidden. And so I'd say in thinking about what's been going on in the last 20 or 30 years, the illness is less hidden, and building off of Dr. Pantilat, if I said that properly, there is more hope. And so these are differences that I think we can say more hope and less hiding. There's more hope in better treatments and and potentially a cure, inspired by the research that's being done by people in this room and the pharmaceutical companies that are represented in this room. And there's less hiding of the illness by making it a little more normalized, even though there's still plenty of people that aren't being reached well by the services that are available these days. As far as the hidden part of the illness, one important event or approach to this was achieved with Charles Sabine, who's here or is at this meeting, who gave an inspiring TED Talk about Huntington's disease in 2004. And he says that at the time, his doctor had said, "Well, there's nothing you can do about this disease, just live your life as well as you can." But these conversations led him to start his Hidden No More Foundation, which achieved that amazing event, the audience with Pope Francis in 2017, where some 1,700, 1,800 people gathered at the Vatican and met the Pope. And the event included some 150 patients from 26 different countries, just a huge turnout and effort. And at that time, the Pope exhorted the Huntington's community to hide no more, saying, "May none of you ever feel you are alone. May none of you feel you are a burden. May no one feel the need to run away. You are precious in the eyes of God." I think in part from these efforts, and again, efforts of people in the room, the Huntington's is less of there's less of a stigma with it. It still exists, but there's less of a stigma. It's not as hidden. So I'll talk about a few cases of folks that I've seen. Everybody's got some examples that they could bring up. But this particular gentleman, there's two brothers, one with a better outcome than the other. One that I saw earlier in my career, and a brother who I saw a little bit later who did better. But Tom was both these brothers, they had Huntington's disease in their mother and on their maternal side, maternal grandmother. He was a machinist for some 20 years He had problems with some inappropriate sexual behavior at age 38 and was seeing a psychiatrist for depression, aggression, and alcohol abuse or disuse. And then when he was 40 years old, he fell asleep while driving at noon and suffered a fracture through both bones of his left leg, a tib-fib fracture, in the year 2000. This difficult leg fracture in somebody who would follow directions would have a complicated recovery, but made much more complicated by his Huntington's disease. So he was transferred to the Duke orthopedic folks when he was 40 and got his leg repaired, but his instructions of his orthopedist to stay off that leg were not followed by him. He continued to try to walk despite the fact that he had a cast on his leg. And he'd go back to the orthopedic clinic and was not being healed appropriately, or his leg wasn't healing appropriately, and they'd have to recast him or consider some surgeries and do some surgeries to try to help with his wound. But he wouldn't follow the advice of his orthopedic doctors. At that point, they referred him over to me, over at the Movement Disorders Clinic, so that was in 2001. By this time, he was estranged from his wife. He was living with different siblings. By the subsequent year, he was at age 42, probably wasn't really independent, but living in an independent apartment. He had his facial expression looks like he was angry all the time, and with a facial dystonia. He would get into fights because people would misinterpret his expression. And then by a couple of years later, he started getting paranoid and went to an assisted living facility. By age 46, he got in a fight at the assisted living facility and had his teeth knocked out. And subsequently, he was lost to follow-up by me. And he died, actually, his obituary says, in hospice in 2010 at age 50. Not a good death. His brother, we'll call Mike, he came to clinic in 2014 after we had a Center of Excellence established, and was referred to the center. At the time, he had mild chorea. He was married, had a stable marriage. He was working as a manager, had a CAG repeat of 41, and his total functional capacity at that time was normal. But he was excited about the opportunity to participate in clinical trials, and had heard about some, probably at a support group. So he participated in an observational study and a drug study over the years. I think it was the creatine study. But by age 61, he was still working, but was having a conflict with his boss and had some mild suicidal ideations. By age 62, he had a psychiatrist that he was working with, and he worked a lot. He worked some with our social worker at the Center of Excellence, and was able to retire from his rather stressful job, and then and did pretty well. He's at age 68. He was following up pretty regularly in the clinic, where they had the physical therapy, occupational therapy, speech therapy, a social worker, and we actually have a chaplain in the center, which we found very, very helpful. He was doing volunteer work at the time. And then age 69, he was driving less. His total functional capacity had declined quite a bit to 6, although his mini-mental status was still pretty good at 27. And at age 70, he's taken a couple of antidepressant-type medicines and a low dose of tetrabenazine. His mobility's decreased, but his quality of life, certainly compared to his brother, and there's a lot of differences, obviously, from case to case, but his quality of life is pretty good, and he's living with his wife. Another gentleman that I'll mention, so the proceeding was kind of the difference between, at least to my mind, simply, is the difference between more availability of interventions, not so much in the first brother, but more so in the second brother to help try to head off problems that could develop. So another patient, we'll call him Grant, came to the clinic when he was 54 in 2007. We actually started our center in 2008, but his wife had noticed a personality change, and he had mild chorea and a CAG repeat of 44. His paternal grandmother had died at age 50 in a psychiatric hospital. She had 12 kids, 12 children. 5 of those 12 children had Huntington's disease, and one of them was Grant's father, who committed suicide at age 45. Grant also had a brother who had Huntington's disease and committed suicide. But Grant and his wife were more knowledgeable about the illness, and they had 2 sons, but they had them through a sperm donor so their kids wouldn't have Huntington's disease. So Grant worked as a hospital safety officer and was followed for 11 years at Duke. We had, at Duke at the time, we had an IND to purchase tetrabenazine from, I guess it was Cambridge Labs in the UK. And so we would purchase the drug using the permission from the IND and sell it at cost to folks that required it for hyperkinetic movement disorders. So Grant was taking tetrabenazine. He was very excited by this intervention and felt that it helped him with his speech, or with his swallowing, actually. And he became one of the folks that went up to the FDA when tetrabenazine was seeking approval, and testified as one of the patients that were given the drug. So Grant was able to work until 2010. Unfortunately, he fell at home and had bilateral subdural hematomas, and gradually declined after that. But he had strong support, and not everybody's blessed with it, but had strong support from his family and his church. He had an incredibly upbeat mood despite his gradual decline. And eventually he went into hospice care and died with his family present in 2018 at age 68. A different kind of course made possible in part by more support that was available. And then one other case I'll mention is a woman and her mother, kind of the difference between the two of them and what was available to them. So Sue and her mother both have Huntington's disease. But Sue's mother had polio when she was a child, and when Sue's mother was a child. But then the mother developed chorea in her mid-60s. But the abnormal movements were attributed to her polio at first. It wasn't recognized as something different as Huntington's disease. But eventually was tested and had a CAG repeat of 44. And Sue says that the Huntington's diagnosis for her mother several years ago was, quote, like a death sentence, unquote, because her new symptoms weren't recognized, again, attributed to polio rather than to her Huntington's. And her mom died 2 years later at age 72. Sue, the daughter, is a 70-year-old woman, a married woman, who had onset of chorea some 9 years ago, and was diagnosed clinically with Huntington's disease soon thereafter that. She has a total functional capacity of 10, meaning she's not working, and maybe a little cognitive difficulty, but is doing well and is able to take advantage of the center and its therapies and the other support that's available in the Huntington's world these days. So Ruth, who I mentioned to you earlier, is a wonderful volunteer with Huntington's disease in her family, volunteer in the clinic, and she asked among her the group of friends and acquaintances that in the Huntington's community, she asked folks, well, how do you think care has changed over the last year, say, compared to what your other relatives went through? And some of the responses are here. One is the internet. The best thing was finding out we weren't alone. We weren't by ourselves. We now have the option of a Facebook group, a patient-focused group, an in-person meetup, an in-person support group, or one of many online support groups. And these options were not available to my family 30 years ago in 1994. And certainly, online support is coming from organizations like HDSA and HD Reach, which I'm pleased to be a board member. HDYO, and other groups. Another response is we're more comfortable with our loved one in public, sort of less of the hiding business. We're more comfortable with our loved one in public, especially at friendly events. And another response was that the ADA for disabilities has brought about more awareness in accommodations for disabilities, and found that to be something that's different, that's been important to them. Other responses have to do with the centers of excellence that are funded by HDSA in part. One respondent says going from zero up to more than 50 centers of excellence has been a good thing for us. We're very pleased with the level of knowledge among everyone on the staff, and exhorting us to see how we can work together as a team to manage challenges. And they found this the most important change in care in the last 30 years. Another comment was improved medications and improved behavior management strategies. So, we have approved medicines for chorea, but then we have the medicines that the psychiatrists use to help with the irritability and depression and anxiety and compulsiveness that can plague patients. And another response has to do with improved therapies, the speech therapy, physical therapy, occupational therapy, and psychological therapies. So, to list some of these things in another way. So the multidisciplinary care is one aspect that's come on the scene and made a difference. The problem being that not everybody is able to reach that. But in the multidisciplinary centers, there's attempts made to try to head off problems before they come. So, for example, the occupational therapists are screening folks for their ability to drive and trying to stay ahead of when folks might not be so safe to drive. The physical therapist, trying to involve interventions that reduce risks of falling, or reduce falls. Better, and the research, again, being done in this room by so many and by pharmaceutical companies to come up with innovative ideas to test out and in the clinic, and to with the goal of better treatments and even cures. And then our beloved social workers who take care of so many complex problems, again, finding resources for people. Everybody's got an example of this. One example that I can give you is we had a homeless patient, a homeless person who was living, he'd sleep on the step of a Methodist church in downtown Durham, North Carolina. He'd roam around during the day and he'd sleep at the church at night. And the associate pastor of that church had taken on, given him some food and trying to get him to some sort of medical care. Urban Ministries was just a block away. I think she tried to get him over there, but learned that there was specialty care for a Huntington's patient and at our clinic. And that pastor worked with our social worker to get that homeless individual to come to clinic. And at the time, he was eligible for Enroll HD, so we could use some of the research funding to offset some of the cost of his care. But he was a difficult patient to get appropriate housing for him. He got placed, but he didn't like the rules of the place that he went, and so he would elope from that place, and then the social workers would find another location for him. He went through a few such placements until he found one that he liked, and he's got Huntington's disease. His Huntington's disease progresses like we know it does, but he's in a safe place, and when he comes to clinic, he's happy about it. I mean, it's a good thing from where he was. Again, thanks to the benevolence of a pastor and our wonderful social workers. Healthcare HD healthcare has also changed from being able to get healthcare insurance despite pre-existing conditions. Although in the current political environment, we'll have to see what happens with that. But coverage for pre-existing conditions has helped many of our patients. And also expansion of Medicaid has helped many of our patients. And my hope part is that our government will see fit to leave these things intact. Certainly, there's also advocacy and support groups that educate more caregivers and physicians, patients, and families. And I mentioned the HDSA and the HD Reach and HDYO and other groups. All are very important. And so, I would say that all of these things lead to, over the past 20 to 30 years, more hope for people with Huntington's disease, and their families through the research that's going on and opportunity for better care that we just need to be able to expand to more people or find the people that aren't getting it. And then secondly, less hiding of the afflicted, more normalization of serious illness like this. And it's just another T-shirt from another patient that says, "Know who else has genetic mutations? Superheroes do." Thanks to everyone here who and in the community that are working so hard to improve things for HD families. I would like to acknowledge our team at our center at Duke. This is a piece of it. Many people are here. None of the social workers are in this group. But two people I wanted to point out is the second from the left is Dr. Katie Moore, who is here, and she's a fabulous young neurologist who's involved with our team and is just doing a wonderful job. And next to her is Allison Lee, who is the chaplain at our Center of Excellence. So we actually have some funding to have a chaplain there every week, and she's been of great benefit to us as well. So thanks for your attention.
Thank you, Dr. Scott. Up next is a session on young people in HD. Please welcome Dr. Katherine McDonell from Vanderbilt University to lead this session.
Good morning, everyone. I'm Katherine McDonell. I am a neurologist at Vanderbilt, and I am really excited and honored to be here speaking with all of you today. I think this is my 10th HSG this year, but it's my first time speaking, and I'm really grateful to the organizers for having me. When Daniel asked me to give a talk about young people in HD, I wasn't entirely sure if he was talking about me or our patients, but we're going to talk a little bit about both. I don't have any relevant disclosures for this talk. This photo is from HSG 2018. That's me, sitting next to three of my HD heroes, Martha Nance, Victor Sung, and Mary Edmondson. This was the Ask the Experts panel at the Family Day that year, and the fourth person on that panel was not supposed to be me. It was supposed to be Daniel Clausen. But in true Daniel fashion, at the last minute, he said, "Hey, can you go sit on this panel for me?" And I was 8 months pregnant. I could not even climb up onto the stools we were supposed to be sitting on. And I in no way felt like an expert. But it ended up being a really great experience, and I found that I did indeed have a lot to say. I think I still feel a little bit like that up here today, just looking up at these giants in the HD field and kind of what I'm doing here. But once again, I'm very grateful for the opportunity. My story starts 10 years ago when I came to Vanderbilt for a fellowship. And I had planned to do a fellowship in cognitive neurology, learning how to manage memory disorders like Alzheimer's disease, frontotemporal dementia, dementia with Lewy bodies. But I had also developed an interest in movement disorders, and I wanted to learn more about how cognitive and movement disorders might intersect. So I started studying impulse control problems in Parkinson's disease. I started learning about some of the fascinating cognitive syndromes you can see in disorders like corticobasal degeneration and progressive supranuclear palsy. And it turned out that around that time, we were also starting our HD clinic. I think I had seen maybe 1 or 2 patients in all of my medical school and residency training with HD. The experience that stood out the most for me was actually during one of our noon conferences in residency, when a young woman came to talk to us. And she told us her story about growing up in a family where her mom had HD, and talked about what that was like during her childhood, having to become a caregiver for her mom at a very young age. And then she told us about her journey of deciding to undergo genetic testing and then learning that she carried the same gene mutation that took her mother's life. And I was just absolutely awestruck by this woman's courage to not only decide to find out this life-altering information about herself, but then to get up in front of a bunch of doctors she didn't know and tell this incredibly personal story. And that really stuck with me for a long time. So when Daniel asked me if I wanted to become part of our HD clinic, and specifically said he needed someone to lead our genetic testing program, I said yes. And I think that decision really changed the trajectory of my whole career. So we started to build our clinic. That's Daniel showing me where the caudate is. And I started seeing all of these young people who were dealing with these heart-wrenching questions of how to plan their lives, how to plan their families, how to plan their careers with this illness looming over them. I listened to their fears, I heard their hopes, their dreams, their worries about the future, and I heard about a lot of the trauma that they had been through while growing up in these families. And pretty soon, I was the one who was delivering that same news that I had found so unimaginable just a few years before. So I'm going to tell you the story of a couple of the young people that I've met in our clinic in recent years. The first one was a young woman I met a few years ago in our genetics clinic. She was 26 at the time, and her father had just been diagnosed with HD. They had no known family history of HD. They'd never even heard about the disease until her dad started to exhibit some really bizarre behaviors. He had some really significant personality changes, and had started to do things that were very risky and impulsive. He had no chorea, so no one even thought about HD. He was diagnosed with everything from bipolar disorder to frontotemporal dementia, until finally his daughter looked up HD on her own and said, "I think this is what it is, can you test him for it?" So they finally sent genetic testing, and it came back positive. So now his daughter was coming in for testing. She had 2 young children, and her main concern was finding out whether or not they were at risk. So we sent testing, and it came back positive with 45 CAG repeats. She came back for her results visit a few weeks later, and she ended up bringing her 4-year-old daughter with her to the appointment. One of our amazing social workers took her daughter out of the room to color while we met with the patient and her husband, and we disclosed her results. She was obviously devastated, but trying to stay strong. And about that time, her daughter came back in the room with a picture she had colored of a woman in a wheelchair. And she handed it to her mom, and she said, "Mommy, I drew a picture of you." And I think in that moment, just the sheer stark reality of this work really came crashing down for me. I don't know how we held it together in that room, but we did. And then we had to go into the next room and tell this young woman's sister that she was also positive. And that is why you need a team to do this work. It is impossible to do this by yourself. I've already made Lisa cry. Sorry, Lisa. These visits are incredibly hard, and they bring up some really difficult questions. The biggest question is usually, when will I develop symptoms, and how will those symptoms affect me? And that is a question that I still don't think we have a satisfying answer to, because we are still not good at defining what the first symptoms of HD actually look like. So we're going to talk today about how we define disease onset in HD and how that is changing. But I first want to tell you about another young woman who I also met in our clinic around the same time, whose story really helped to shape the way that I think about this. So she was 24, had a family history of HD on her mother's side. Her mom had been diagnosed in her early 30s while she was in a psychiatric hospital, and she had a grandmother who had died in her 40s. Our patient had 4 young children and was very concerned about both her risk and their risk, especially given that her mom's symptoms had started so early. She came in with her partner, was in a stable relationship, had a steady job, and was just trying to provide for her kids and be the best mom that she could for them. So we sent genetic testing, and it came back positive with 51 CAG repeats. She had no motor symptoms. She had no mood symptoms. She had no cognitive symptoms. She scored a 0 on the UHDRS, and for all intents and purposes, this was someone you would consider completely asymptomatic. We talked about her results and talked about what that meant, and came up with a plan to monitor her. So she came back to our clinic a few times after this. She started to have some depression, so we referred her to our psychiatrist and started her on some medications. She started to notice some memory problems at work, so we referred her for neuropsychological testing, which did show some mild executive dysfunction. And shortly after that, she disappeared. She stopped answering phone calls, did not respond to text or emails. We tried and could not reach her for over a year, until she finally sent me this message on our patient portal saying she needed to speak with me. So we got her in for a visit immediately, and we learned that she had started using drugs, had broken up with her partner, had lost her housing, had lost her job, had lost custody of all 4 of her kids, and was living in a hotel in a really unsafe situation until she was finally admitted to rehab, where she had to undergo detox from alcohol, methamphetamine, and benzodiazepines. She had just gotten out of rehab and called us wanting to get back on her medications and try to get her life back together. And I wish I could tell you this was the only time this happened, but we have seen these cases over and over again in our clinic. Patients who are coming in with no motor symptoms, but these really severe psychiatric and behavioral problems that were just upending their lives. I unfortunately have more examples of these than I can count. And I think a lot of us in this room who treat HD patients probably have very similar stories, but I wanted to go through a couple of other cases that we've seen recently. We follow a 27-year-old woman whose first presenting symptoms were hypersexuality and impulsive spending. She had maxed out multiple credit cards and contracted multiple STIs. A 41-year-old who I follow, who has had decades of severe depression, anxiety, suicidal behavior, substance abuse. He's been incarcerated multiple times on drug-related charges and assault. He's had multiple prior psychiatric hospitalizations and rehab stays. He's divorced from his wife and struggling to maintain a relationship with his 2 sons. And all of this started years before he ever had any motor symptoms. A 23-year-old in our clinic who came in with irritability, intermittent explosive disorder, and very risky impulsive behavior, including driving to another state to meet a man that she had met on TikTok with her 2-year-old daughter in the car. A 39-year-old that I follow who's had severe anxiety depression, had a previous significant history of opioid abuse in her teenage years, leading to loss of custody of both of her daughters, who are now ages 15 and 22 and living with her mom. A 20-year-old who had a history of polysubstance abuse, including bath salts, alcohol, and codeine, who came in with objective cognitive deficits on exam, apathy, irritability, had been in multiple altercations, had had multiple car crashes, finally stole a car from a dealership and went on a multiple-day joyride until he was arrested and sent to a court-ordered substance abuse rehab program. And he developed motor symptoms many years after this. A 27-year-old who came in with worsening depression and anxiety, suicidal ideation, insomnia, very impaired judgment and decision-making, and very impulsive behavior, including misusing his father's disability checks and being charged with fraud. And finally, a 38-year-old who just tested positive in our clinic with 45 repeats after he'd spent the last 12 and a half years incarcerated on drug-related charges. These are all real stories from our clinic. None of these patients had a motor diagnosis when they first presented. So it is very clear that in our clinical experience, cognitive and behavioral problems happen first, they happen early, and they cause significant stress and functional impairment in these people's lives. People lose their jobs, they lose their housing, they lose their relationships, they make extremely poor financial decisions, they start using drugs, they get arrested. And a lot of these problems go unrecognized. Many of these patients are not diagnosed when these things are happening, they're not established with a clinic, and they're not participating in studies. And what we realized was that even when they were, we were not doing a very good job of asking about these types of behaviors. And even for patients who we were following, we were not finding out about these issues until they had already caused severe consequences. So the first thing I did was to develop a questionnaire to start asking about them. And we found that we weren't wrong. In this pilot study of 60 patients and 60 caregivers, 80% of patients and over 90% of caregivers endorsed at least one risk-taking behavior, and these behaviors showed a strong negative correlation with age, suggesting that as we were seeing in clinic, these things were happening early in the disease course. I was a little afraid at first that people may not want to tell us very much because we were asking some pretty tough questions. But that turned out not to be the case. There was actually kind of a sense of relief that someone was even asking about these behaviors and finally acknowledging that they could be a part of HD. I'm not going to read through all of these quotes, but some of them are pretty heartbreaking and just kind of give you a sense of the spectrum and severity of these behaviors that people were reporting to us. And as I was looking through our data, I noticed something else too. Again, this was a retrospective study that only included adults. but so many of our participants were talking about things that had happened during their childhood and adolescence. So I started to wonder what is going on with these kids. While we were doing this study, we had also begun to build a collaboration with a child psychologist at Vanderbilt named Bruce Compass. And so we started bringing in parents with HD and their kids, and for the first time, we started to ask our patients, how are your kids doing? And it turned out that a lot of the time, the answer was not very well. This one was really our wake-up call when one of my patients brought in his 16-year-old daughter, who we learned had been struggling with substance abuse and depression since her early teenage years. We worked to connect her with psychiatry. We were able to get her into our partial hospitalization program, and she was doing better until she unfortunately relapsed and died of an overdose at age 19. We've seen a lot of other really difficult cases as well. This is the daughter of another one of my patients who was 11 and having severe behavioral problems. She's been suspended from school, she's kicked her teacher, chased her sister with a knife, has been admitted to inpatient psychiatry, diagnosed with multiple mood disorders, and started on an antipsychotic. A 12-year-old girl with a history of ADHD, anxiety, depression, and self-harm behavior. She started having auditory hallucinations and nightmares about setting the house on fire and killing her father after her grandmother died from HD. She threatened to kill herself with a knife and was admitted to inpatient psychiatry. A 17-year-old young man who a lot of us in our clinic know, who ended up being tested at age 7 due to mood swings and found to have 52 CAG repeats. He struggled a lot with depression, anxiety, and panic attacks. He made a plan to kill himself at age 18 and attempted suicide at age 17. He was fortunately unsuccessful and is now doing very well, but has really struggled a lot throughout his life. And finally, an 18-year-old who I just saw a couple of weeks ago in our genetics clinic, who has had multiple psychiatric admissions since age 7, when he was admitted twice for running into traffic and assaulting his mother. Since then, he's had severe depression, anger and aggression, explosive behavior. He's had multiple suicide attempts. He's also exhibited impulsivity and risk-taking behavior, including eloping from home and putting his arm out in front of a truck. So all of this really brings us back to that ultimate question of when does HD start? Our approach to staging in HD has evolved a lot in recent years and is still evolving. I think we all recognize at this point that relying on motor onset does not adequately capture the full spectrum of this disease, and it also minimizes the really significant cognitive and psychiatric symptoms that happen first and cause real impairment in people's lives. We have started to include cognitive impairment in our staging framework, and this paper was one of the first to do that. But cognitive symptoms in HD are not a monolith. They are incredibly diverse. Some start early, some start later, and we really don't have a full understanding of how these evolve over the disease course. In addition, psychiatric and behavioral symptoms have not been included at all in any of our traditional HD staging frameworks because they're messy. They don't follow these nice curves. They vary a lot from person to person, and people with psychiatric problems are oftentimes not included in studies. But it is critically important to understand these symptoms, both to help people who are suffering and because they are often the earliest presenting symptoms. And if we are truly going to modify the course of this disease, we have to understand the earliest symptoms, which means we need more sensitive measures to detect the neuropsychiatric changes that happen very early. The Neuropsychology Working Group is doing some great work right now to develop non-motor diagnostic criteria that can help better define these neuropsychiatric symptoms and change the way we think about disease onset in HD. But I think we still have a lot of work to do in this area, especially now that we have disease-modifying studies actively in clinical trials. This is our newest staging system, the HD-ISS, which includes biomarkers as indicators of disease progression for the first time. This is huge, and I think there are definite advantages of this staging framework. I appreciate that it does include a discrete cognitive measure for the first time, but I'm still not sure this fully captures what we see in clinical practice, especially in early HD. I think what we really need to know is what happens in stage 0 before someone develops measurable atrophy. In addition to my work in HD, I'm still a cognitive neurologist. And if you've followed any of the research in Alzheimer's disease over the last several years, the main lesson has been that we're waiting too late to intervene. In my clinical practice, seeing atrophy on an MRI is a late sign of disease. And there are often changes that I can detect on my cognitive testing before this occurs. So just like waiting for motor onset is too late, I think waiting for atrophy is also too late. So the question is, are there biomarkers that can be measured before neurodegeneration begins? And I know there's a ton of work going on right now to identify blood and CSF biomarkers in addition to these imaging biomarkers. But I think we need cognitive biomarkers as well, and I think we need to think far beyond the cold executive tasks that we've relied on in HD up to this point. Finally, and importantly, all of the studies that our staging systems have been based on, like the vast majority of our longitudinal studies in HD, with a couple of recent exceptions, have only included people over the age of 18. So we really don't know what is happening in children and adolescents, and this is what we have to figure out if we're going to have any hope of stopping this disease before it starts. So I'm going to tell you about some of the work our lab is doing to try to fill in the gap of what happens in stage 0. And what we're finding is that there are, in fact, detectable changes in children far earlier than has been previously shown. This was a paper by Anna Falzer that was published last year that examined several different measures of executive function from the NIH toolbox in 110 participants ages 7 to 39 who had a parent with HD. Participants underwent triple-blinded genetic testing, which allowed us to take their gene status into account without anyone being aware of their results. And we found significant deficits on both the composite measure of executive function across the 5 tasks, as well as a separate measure of working memory in those with gene expansions, with differences starting to become apparent at age 18. Secondly, we've also continued to build our strong collaboration with our child psychology team, and we've started to look at the impacts of stress and coping in young people who are at risk for HD. This was some work by Abby Cerigio looking at adolescent and young adult offspring ages 10 to 29 who had a parent with HD. And she found that those at risk for HD had significantly lower working memory scores compared to normative data and significantly higher scores on anxiety and depression. These impairments in working memory were also correlated with reduced secondary control coping skills, which was in turn associated with more psychiatric symptoms, suggesting that early cognitive changes might impair at-risk adolescents' ability to cope with stress. And here are some of the first data for my study. For this study, we are bringing in 100 adolescents ages 10 to 18, half of whom are at risk for HD and half of whom are community controls. Participants complete a series of cognitive tests, psychological and behavioral assessments, and a detailed stress questionnaire. And they also complete 4 different cognitive tasks while undergoing continuous EEG monitoring. We're still recruiting for this study, but I'm excited to present some of our preliminary results today. The first measure we looked at was a stress inventory called the STRAIN, which is a comprehensive assessment of lifetime and recent stressors across multiple domains. And we found that adolescents at risk for HD scored significantly higher than their peers on every core subscale of this measure. We next looked at interactions between stress and psychological symptoms in our 2 cohorts, and we found something really interesting. In controls, stress correlated primarily with internalizing problems, particularly anxiety. But in the adolescents who were at risk for HD, increased stress instead correlated with externalizing problems and rule-breaking behavior. This suggests that not only are children from HD families subject to more stress, there's something fundamentally different about how they respond to that stress that might predispose them to developing problematic behaviors. And we're now starting to get some clues as to what might underlie some of those differences. These are ERP data from a monetary reward task in which participants choose between 2 doors to try to win money. We looked at an ERP component called the reward positivity, or RUP, which is a reliable marker of reward responsiveness, and we found that our at-risk participants showed less of a response to wins compared to controls, and showed no significant difference between win and loss trials, so their RUP was relatively blunted. This suggests that at-risk adolescents may have altered reward processing, which has been shown in adults with pre-manifest HD, but has not yet been studied in children. There are a couple of things to consider here. First, RUP can be modulated by both stress and depression, so we may be seeing a combined influence of both environmental and biological factors here. We did look at correlations between reward responsiveness and psychological symptoms, and even though there were not significant differences in psychological symptoms between our two cohorts, we found that RUP amplitude was correlated with aggressive behavior, externalizing problems, and total affective problems in the at-risk kids, but not in the controls. And these associations remained significant even after adjusting for stress. The second thing I will note is that while all of our at-risk participants have provided a sample for blinded genetic testing, we have not yet included these data in our analyses. So this is a mixed genotype sample. The next step will be to take gene status into account while trying to disentangle potential environmental effects from biological effects. But I do think it's really interesting that we are seeing such striking differences in kids from HD families compared to controls without taking genotype into consideration. I think this has important implications for not only how we support these families, but also how we plan our studies and how we think about control groups, because it looks like community controls and family controls are probably not the same. And we have a poster here as well. I think it's poster 71. Come visit Liz if you have not. All right, I want to give a quick shout out to our youth and family research program at Vanderbilt. We have a large and growing program of research studies that are recruiting children and parents from HD families to learn more about early behavioral changes, stress, and social relationships in these families. The first one is my study that we've talked about. We still have a few spots left for at-risk kids, so if you have any families that might be interested, please send them our way. We're also running a very large longitudinal study looking at social connectedness and isolation in these families. My colleague Kelly Watson is looking at cognition and relationships in teenagers. Abby Cerigio is leading a new study looking at stress, inflammation, and cognition in young adults who are gene positive. We're also very excited to be a site for Change HD, which is a longitudinal study for young people between the ages of 6 and 30 based out of the University of Iowa. Tiara Willis is our project manager, so if you have any families that might want to participate, please reach out to her. A lot of these studies can provide assistance with travel funding as well, so it makes for a nice all-expense-paid trip to Nashville. Finally, I want to thank my team. Again, it is just not possible to do this work alone, and I could not do this without you guys. So thank you. I'm very grateful to have an amazing team at Vanderbilt that helps me in everything that I do. And with that, I'll leave you with a few final thoughts. First, ask your patients how their kids are doing. You will learn a lot. Secondly, don't exclude people with psychiatric problems from studies. We should be recruiting them. We need to learn from them. Third, we need to think about the impacts of stress and environmental factors in HD families, both in learning how to support these families better and also in thinking about our control groups. And finally, to intervene earlier, we have to diagnose HD earlier. And to do this, we have to broaden our understanding of early cognitive and psychiatric symptoms and get better at measuring these. Thank you all so much.
We are going to do the Q&A, so if you just want to stay. Okay. Thank you. At this time, I'd like to invite Dr. Pantilat and Dr. Scott back to the stage. We're going to do a quick Q&A before we take a break. If anyone has a question, if you could just raise your hand, and we will bring the microphone to you. I see one in the back, right back here. Oh, we'll come to you next. Did you have a question?
Yes.
Go right ahead.
Hi. Claudia Testo, University of North Carolina. Thanks, I enjoyed all those talks immensely. Gave me a lot to think about. A key thing that ran through all three talks was the importance of care professionals and a variety of care professionals on the team. I would love any insight as to how you get these people sustainably funded outside of a cancer center. Please do not say Enroll HD. I am a convert, but there's not an Enroll HD site at every single place. And also, working in state safety net institutions, if you're not in a private institution, sometimes by law, you cannot mix those research funds over into clinical care, not sustainable. Please don't say philanthropy, because fundraising every year and wondering if I'm going to fire someone is not sustainable. I would love any suggestions for case management, social work, chaplain, nursing. I will take any pitch that I can justify to the health system I now work in. Thanks.
Thanks for the question. Go ahead.
Hi, Claudia. So we are funding a part of a chaplain through our HDSA grant. And we are funding part of our social workers through the HDSA money as well, but also. So patients are paying for it? Because that's donating to HDSA. Okay. So yes, then if that's from donations to HDSA, that's part of our budget, yes. Also from Parkinson's Foundation. I think the department covers some of it. But as far as the therapies, physical therapy, speech therapy, occupational therapy, their departments have deemed having a multidisciplinary clinic to be useful to Duke and are allowing their therapists to come to clinic. When we got started, it was, can we justify them being able to bill enough to justify their existence? Can they bill enough to make their department happy? They still bill for their services, but we've been doing it for several years now, and the departments also are willing to, I guess, cover any deficit that's there based on feeling that it's good for their department to have this representation. And also their therapists like being in the clinic, so they express that to them. So part of the money is coming from the departments, part of it's coming from HDSA.
I'll just add, we have this challenge, and I have this, so yeah, thank you. We have the same challenge in palliative care, and I appreciate you recognizing the importance of the interprofessional team. I think just listening to your stories, I think it's like impossible to do this work without it. So I think you're right to think about how to get these different disciplines engaged. What we talk about in our field is just, continually making the case, telling the stories about how we take care of patients. Whenever I get feedback that our social worker, helps make something happen, I just forward it, throughout our leadership team and just continue to make the case so that, I think about it as like if you're surfing and you're trying to catch the wave, you got to be in the water on your surfboard, with your wetsuit on. And so we're just always talking about the need for chaplaincy and social work, which are the two hardest disciplines to get for us. And just always talking about the value and how important it is and really trying to promote them so that when those opportunities come, that there is some hiring happening we try to get to the front of the line. Our social worker in our clinic was the most productive social worker. He saw the most number of patients, left the most number of notes, and I can't tell you how many stories there are of getting services for patients, getting back Social Security payments for a patient with Lewy body disease by going down to the Social Security office with him and his wife to sit there for 4 hours to make the case. Those kinds of stories do go a long way, and we just keep making the case.
I had a question, please. I'm Diana Rosas from Mass General Hospital. I've been treating patients for a really, really long time. And for the first time this year, I've had several of my patients talk about physician-assisted death, physician-assisted death. I wondered, one, on just the issues in terms of palliative care, because that seems to be, how is that copacetic? Because we're really focusing on quality, and now they're really talking about trying to shorten things. I'm also kind of torn about this, how I feel as a physician, because I struggle so hard to try to do the best I can to keep encouraging them and keeping them positive, and then they're talking about this, but they're also talking about celebration of life and kind of getting through their bucket list. And then the last part of that's complicated. I'm just sort of, as I said, wrestling with a lot of this as a physician who tries to, give people as much quality as they're able to, but in terms of the requirements also for patients who are considering this to be cognitively intact, which means that many of our patients who may be considering this need to consider it in many cases far earlier than I think many of us would feel comfortable actually recommending that, or if we were to actually, or supporting that, I should say. So just again, just these random thoughts, if I could get your thoughts and input would be really appreciated. Dr. Pantilat.
Sure. Medical aid in dying is legal in California, and it is something that we deal with regularly in our clinic, in our palliative care clinic. Typically, if you look in the United States, the requirements are a 6-month prognosis, as you said, cognitively intact, and able to self-administer. And for a lot of people with neurodegenerative illness, they're not cognitively intact by when they have a 6-month prognosis, and so they are not eligible. So our patients with dementia, for example, largely are not eligible. There's a push on the advocacy side towards people being able to make the request when they are cognitively intact, and that request being honored when they have a 6-month prognosis. But that is not the case yet. That is not legal anywhere, but that is where things are moving. There is an opportunity. I mean, I see the request as an opportunity about what it is people are worried about, what it is that they're concerned about. I will say that if you look at the data, and I think in neurodegenerative disease, you see it a lot in ALS, the concerns really they're not about pain by and large, although people do worry about it, but that's not the biggest concern. It is about control over your life and over the end of your life, and not wanting to end up in a situation that you just don't want to be in, that you are very dependent. And I think one of the most troubling things we have found in the research that we're doing around this topic, particularly in ALS, is just that these are issues that I don't know that we can fix. That these are fundamental issues about how people experience their lives and their suffering and their dependence that I don't know that any of us can fundamentally fix. And most of the patients who ask about it on their very first visit with us and are very, very determined. It's still a very small population. But what I think about is when the request comes up to take it very seriously and to ask what it is people are concerned about. If you're in a state where it's not legal, it's just not legal, and so you can think about what else you can do and how we can help patients. And where it is legal, people struggle with it a lot. I struggled with it a lot myself, and yet patients make very compelling cases for why this is right for them and why they feel, compelled to do it. I feel sad when people do it, and I feel like, my job is to help them live well, like I said, and I feel like it's a bit of a failure on our part, but again, I take some comfort in the fact that the issues that they're expressing to me, I don't see are fundamentally things that I'm able to undo or in fundamental ways make better.
They're going to Switzerland.
Some people are going to Switzerland, yes, absolutely. Yeah. Yeah, I mean, there was that book recently written about the woman who helped her husband with Aiden dying in Switzerland. Yeah, they are. But you got to have a lot of money to go to Switzerland to end your life. I mean, that's not available to most people, even in Switzerland.
We have time for one more question. If you have a question, can you raise your hand and we'll bring the mic to you?
Yeah, sure.
Right here.
Yeah, so first of all, thanks for all the wonderful talks. I just had a real question for palliative care. I think I'm not alone, really. For many folks, really, the access to neuropalliative care is a big issue for many of us. I think a lot of us probably have like an oncologist who does palliative care, but that's not really sufficient for our HD patients and even for our other neurodegenerative disorders. So I'm trying to think of sort of how do we create a network or sort of access for folks who don't really have that, because I think it really makes a difference when someone has a background in the disorders that we're seeing and how they approach a patient, particularly an HD patient. This is different, okay? You don't want an oncologist. It just doesn't make sense. So
Yeah.
I want some ideas.
Sure. So a great point. Neuropalliative care is a growing area of interest. There is the International Neuropalliative Care Society. Benzie Kluger at Rochester started it. I would encourage anybody with an interest to get engaged with that. We are training more neurologists in palliative care. I think that's a really important resource. We have a neurologist who's part of our division of palliative medicine. It's made a huge difference in just the ability to outreach and really understand the illness. I guess I think it really is a two-way street. I think these partnerships between palliative care and neurology is really, really important. And I am not a neurologist. I take care of a lot of people with neurodegenerative disorder. I always say, what I knew about Parkinson's disease or ALS would not fill a 3x5 card when I started taking care of patients. I don't know that I ever saw a patient with ALS. I saw a couple of people with Parkinson's disease. I had one patient in my whole practice. I had an outpatient in my outpatient primary care practice early in my career with Huntington's disease. I didn't know anything about it. I mean, really, she had all the things you talked about. I really didn't know anything about it. But I can learn. And I need you to teach me. And we have these really strong partnerships that have developed. And I've learned a lot about these illnesses. And it's true that an oncologist has no training in neurology, but they can learn. And I would really encourage you to reach out and teach them. And when we've written about these issues, I think one of the things we realize is that the education really has to go in two ways. And, if you teach us what this is about, we'll learn what we need to learn, and it will promote the research that needs to happen. And wherever we have these close partnerships, whether it's in ILD or neurodegenerative diseases or hepatology, I think there are real opportunities here to make it happen. I think the real challenge, to be honest, is not about some of it is the interest, but I think what you'll find is that your palliative care colleagues are somewhat overwhelmed with referrals, and they may not be open to neurology referrals because they're just overwhelmed with the cancer, for example, and they're understaffed. And so I think this is a place where partnership can really help a lot to make the case for more staffing, for developing partnerships that really open up the clinic to people with neurodegenerative disorders, with Huntington's disease, and helping together to make the case for why this partnership is so important.
Thank you, Dr. Pantilat. Thank you, Dr. Scott, and thank you, Dr. McDonell. Let's give them one more round of applause, please. Thanks for your time.
Thanks. Thank you.